Greetings and welcome to this module on practical use of semaglutide, tirzepatide, and dulaglutide, which is the most trending topic among Indians nowadays. Uh, so, this is a guidelines-based clinical approach for physicians for practical scenarios and use cases in case of diabetes, obesity, and cardiovascular risk and CKD. The advent of GLP-1 agonist with GIP, such as tirzepatide, dulaglutide, semaglutide, has been mind-boggling and is even able to reverse the process of diabetes mellitus. So this is completely for educational purposes. It's medicine beyond Harrison's. Let's get started. So why these drugs matter today? These drugs are very, very important nowadays in the revolution of glycemic control. The shifting from sugar lowering to metabolic restructuring is the main priority of GLP-1 agonists. Weight management. This is the first non-surgical options approaching bariatric efficacy. So in a long time, the only drug that can come to the close of bariatric surgery is this GLP-1 agonist. In fact, is significant in reducing weight and reversing diabetes mellitus completely. For example, a 93-year-old for example, a 92 kg weight man with a HbA1c of 10.6 started on GLP-1 agonist have lost significant amount of weight in 6 to 8 months, coming to a weight of 78 kgs and HbA1c lowering to 6.4. In fact, reversing the diabetes, and he further needs no medications. So, such use cases are there for GLP-1 agonist, and its time time is to be tested for its side effects and efficacy in the upcoming days. So organ protection, it is significant protection against atherosclerotic cardiovascular disease and CKD risk. There is a strong guidelines endorsed by ADA 2024-2025 and AAC. So this is the most talked about drugs these days in the market. So mechanism overview, it is basically GLP-1 receptor agonist, which is semaglutide and dulaglutide. These are agonists of the GLP-1 receptor, whereas tirzepatide is a dual agonist, acts on both the GAP and the GLP-1. It is glucose-dependent insulinotropic polypeptide, that is GAP and GLP-1 receptors. Both these constitute the effect of decreased appetite, decreased gastric emptying, increased insulin, glucose-dependent increase in insulin. So that means it does not even cause hypoglycemia and decreased release of glucagon, increased cardiovascular and renal protection, which is the most important and effect of these drugs, and the most sought of effect for these drugs, and becoming the prime priority and first line drugs for patients with CAD, CKD, and for diabetes management. So clinical impact is very, very high. So these days, semaglutide have approaching effect of 15% weight loss, HbA1c reduction of 1 to 1.8 in 3 months time. Tirzepatide with 2.3 to 2.5 percentage decrease in HbA1c, and weight loss of very high can exist even 20 percentage. That is, a 100 kg man can reduce his weight by 20 kg and become 80 kgs. In fact, decreasing a lot of insulin resistance in the body, and may even helps in reduction HbA1c, sometimes in the reversal of diabetes. Dulaglutide has moderate effect. It's so cost effective. HbA1c reduction is meager with 1 to 1.5%. There is a strong evidence in cardiovascular risk reduction for semaglutide and dulaglutide, so which is currently the first line drug for these cases. The indications, according to ADA, AAC, and AGA, for type 2 DM, the standard therapy for type 2 DM is nowadays GLP-1 agonist. It is preferred in case of obesity, atherosclerotic cardiovascular disease, CKD, or high risk of hypoglycemia. So, in most of the cases, this covers under the indications and becomes the first line therapy for neurodegenerative type 2 diabetes mellitus nowadays. Without type 2 diabetes, this can be used as a treatment for obesity also, with a BMI of more than 30 kg or 30, or BMI of more than 27 with comorbidities such as hypertension, dyslipidemia. It is also having a lot of cardio-renal protection with atherosclerotic cardiovascular disease for semaglutide, dulaglutide. For CKD, semaglutide is preferred because there is a lot number of data for renal protection. So contraindications are very few. Only these contraindications that you must remember as a physician before initiating a GLP-1 agonist or GIP GLP-1 agonist to a patient. The family history, personal history of medullary thyroid carcinoma is very important, as this can aggravate or increase the risk of medullary thyroid carcinoma. The higher incidence of medullary thyroid carcinoma have been reported. Men 2 syndrome also you have to be careful with regards of using GLP-1 agonist. In case of pregnancy and breastfeeding, there is lack of data regarding these use cases, hence it is avoided. Caution is severe gastroparesis. In case of diabetes, many patients have autonomic dysfunction and leading to gastroparesis already. In such cases, considering GLP-1 GIP agonist is a tricky choice because it will further aggravate the GA side effects. Active gallbladder disease, try to avoid because it has increased propensities to cause in gallbladder stones and may even lead to acute cholecystitis. Rare pancreatitis are used with caution in these cases, as it can aggravate the risk of pancreatitis. Semaglutide practical dosing is worldwide. It is preferred to start at 0.25 milligram weekly and try to taper to zero point 0.5 to 1 milligram, then to 2 milligram. The obesity target is 2.4 milligram weekly. This should be increased gradually with a zero point 0.5 milligram weekly for up to 4 weeks initially, then to convert it to zero point 0.5, then to convert it to 1 milligram, then to 2 milligram as tolerated. So that is one. We have very important point is it is slow titration. These avoids nausea, hence do not escalate during the other illnesses also. In case of oral therapy is also available for semaglutide in the formulation of Ribelsis. So this is 3 milligram per day or 30 days morning taken 45 minutes before breakfast, like a thyroid medication. Then later after 30 days, you can titrate it up to 7 milligram. Then later if tolerated up to 14 milligram per day, this is the targeted dose. So despite practical dosing available in market in India in form of Mounjaro, initially started 2.5 milligram per week for 4 weeks, then titrate to 5, then titrate to 7.5 after 4 more weeks, then finally titrate to 15 milligram per week. That is the maximum dose. It is the most potent dual agonist available currently. The GAD side effects are dose dependent. So highest dose, more GA side effects, low dose, low GA side effects. So increase the dose as the patient tolerates. Dulaglutide, it is available in the market as supplement. Start at 0.75 milligram weekly, continue for 4 weeks. Then, if tolerating, titrate it up to 1.5 milligram, then to 3 milligram. The target is 4.5 milligram per week. It is best tolerated with fewer GI side effects for me. It has a very strong cardiovascular protection. And for geriatrics, it is a good choice for elderly because it's available in simple pen and also good tolerance. Also reduces helps in reduce weight. So use cases for metabolic syndrome, a patient profile is obese type 2 DM with HbA1c of 9.8 and non-alcoholic fatty liver disease. Best choice here is Tirzepatide because of maximum weight loss potential, maximum HbA1c reduction, and evidence for liver fat removal. So in case of metabolic syndrome, we prefer Tirzepatide over semaglutide or dulaglutide. In case of elderly patients with cardiovascular risks with multiple polypharmacy and mild diabetes, so preferred choices dulaglutide, just a modest HbA1c reduction of 1 to 1.5 percentage with a superior cardiovascular protection, better GI tolerance profile, and simple device with a pen type which helps with polypharmacy. We are focusing mainly on the weight. A middle-aged man with BMI of 32, pre-diabetes. There is also in case of females postpartum weight gain. Target these. Semaglutide 2.5 milligram is the best choice because it is the best specific obesity evidence as per STEP trials. This prevents progression to type diabetes. So renal complex for CKG stage 3B up to CKD 3B, semaglutide is very preferred. Dulaglutide can also be used. Insulin-induced hypoglycemia is present for these patients. So try to avoid hypoglycemia with the use of GLP-1 agonists. Renal protection is present for semaglutide, dulaglutide. Hence, it is very preferred. Allows insulin dose reduction gradually. Over days goes by, you can even stop the insulin when the target glycemic levels are achieved with semaglutide or dulaglutide. So pre-initiation checklist before starting, you have to always check for EGFR, kidney function, liver function test, and HbA1c. Review the GA history if there is presence of gallstones. Use with caution. Insulin and sulfonylurea adjustment reduced by 20 to 30% to avoid hypoglycemia. Counsel on the nausea and fullness that the patient may experience. In some cases, even diarrhea. If there is previous history of pancreatitis, it is very red flag and try to avoid GLP-1 GIP agonists. Monitoring short term 1 to 4 weeks to monitor for GI tolerance, hydration status, blood pressure. Blood pressure may drop slightly than the normal range. If a patient having 150/90 blood pressure, it can go up to 110/70. Such cases may drop, so hence monitor blood pressure on each clinical visit. So median term up to 3 months, you have to monitor HbA1c, weight, and renal function. This is where the weight monitoring comes into play. With a minimum usage of 3 months, there is a modest decrease in the weight. Long term, always watch for retinopathy. Retinopathy, there is a risk of retinopathy being increased with the use of GLP-1 agonists. To monitor for fundal examination and look for retinopathy. Gallstones also, look for gallstones on long-term basis after more than 3 months of therapy. De-escalation, reassess a need for other diabetic medications. So when the GLP-1 agonist makes the glycemic control well within the range, try to avoid other or stop using other diabetic medications such as sulfonylureas, insulin, which can further aggravate the weight gain. So anesthesia, try to hold any general anesthesia due to increased aspiration risk because of decreased gastric emptying risk. So hydration, avoid dehydration because of increased renal risk, especially on SGLT2 inhibitor. Sarcopenia, muscle loss happens with rapid weight loss. Ensure protein intake and resistance exercises to avoid sarcopenia. Avoid rapid dose increases because it may lead to increased gastric intolerance. So finally, how to choose for maximum weight loss efficacy? Go for Tirzepatide if you have no other reason to use a GLP-1 agonist. For best cardiovascular benefit, use Dulaglutide. For CKD and proteinuria benefits, use Semaglutide. Case of elderly patients, it is available as a single penicillin type. Hence, Dulaglutide is preferred. For non-diabetic obese patients, Semaglutide 2.5 milligram or Tirzepatide is preferred. Need an oral option? There is oral Semaglutide available. For cost sensitivity, Dulaglutide is preferred. Practical counseling always advice for eating slow, small, protein-rich meals. Stop before feeling full. Avoid high fat foods, which triggers nausea. So expectations, hydrate well. Nausea is common for 2 to 6 weeks. So once initiation of a GLP-1 agonist, you must well educate the patients that there will be nausea for 2 to 6 weeks in spite of low dose, starting at low dose. So weight plateaus at 6 to 9 months. There will be decrease in weight gradually with, up to 3 months, and then 6 months the weight loss plateaus at peak, and up to 9 months there will be no further weight loss. They will report severe abdominal pain. Uh, so always educate there may be occurrence of abdominal pain. So, so, so always look for retinopathy. These are the things that physician often miss. So rapid glucose drop can trigger this. To always check eyes. False loop TSS common during rapid weight loss phase or combo. When GLP-1 receptor antagonist SGLT2 is a powerful for cardio and renal health. So this is the best combination that one can use if there is no problem with the cost effectivity of the drug. If the patient can afford, try to put these medicines. Then also ensure that SGLT2 inhibitors are used in appropriate cases. Case of recurrent urinary tract infection, try to avoid SGLT2. Otherwise, it's a very good drug. It also aids in weight loss and also good benefits cardio and renal health. So reduce drugs reduce cravings. Use this to build habits. So reduce eat less. Sarcopenia, manage muscle mass by actively working out, strength training, resistance training, and good protein intake. So always document for the indication of starting the GLP-1 agonist. Always look for contraindications with literally thyroid carcinoma meant to counsel the patient regarding nausea and pancreatitis. Tell about and educate about the titration plan and the adjunct plan of reducing insulin or OHAs as an unnecessary. So Tirzepatide, it is the most potent as of now, but it is a bit costly compared to the other two. Semaglutide is best for obesity and renal impact. And Dulaglutide is best cardiovascular safe drug or cardiovascular protective drug, and it is best tolerated for elderly patients. The game changes in metabolic medicine when titrated safely. So it can even help in reversal of diabetes, which is the upcoming concept in diabetes management. So for more evidence-based videos, subscribe to this channel. This is Medicine Beyond Harrison. Hope you learned something in this video. Let's meet in another video. Thank you for watching.